Any questions or anything before we get started? Anyone want to know how my vacation was last week?
Yeah.
It was like this. It was awesome. Yeah, I crowd surfed at Metallica. So that was pretty cool. I have a couple of new bruises that I don't know how they got there. All right. Cancer 101. So when we say the word tumor, there's a little bit of confusing nomenclature. There's a lot of like lay use of these terms. So a tumor really is just any swelling. We often use it to refer to neoplasia, but technically like a seroma or a hematoma is a tumor. The word tumor just means a swelling. Neoplasia literally means new growth, neo versus plasia. So that's cancer. That's the cancerous tumor. Oncology is the study of neoplastic disease, whether that's causes, diagnosis, treatment, etc. We're going to talk a lot about differences between benign and malignant tumors, but in short, benign tumors are well behaved. They're rarely going to kill the host, whereas malignant tumors are aggressive. They are not well behaved, and they are much more likely to kill the host that they're in. Cancer. So this one is one I don't love. I use it colloquially, but other people use it differently. So lay people that are not in medicine, when they say cancer, they mean a malignant neoplasm. When I say cancer, I mean any neoplasm, right? When most lay people hear the word cancer, they think this is a malignancy. So you need to kind of be careful the way you approach this in vet med when you're talking to your clients. If a dog has a mammary mass that's benign, you may not want to say, hey, your dog has mammary cancer, because they're going to interpret that as the worst case scenario and you're going to have to bring them back down. So I go back and forth in here. When I say cancer, I'm usually just using it to say neoplastic anything, but it does have the meaning of malignancy. Cancer, like the sign cancer, also carcinoma. We use that word a lot to refer to cancers. This means crab. So it describes like the morphology of an invasive tumor that's actually like crawling into tissue with little crabby arms. Okay, all neoplasms or cancers or tumors. Again, I also use tumors to refer to neoplasms because I assume you guys know what I'm talking about in here, right? Anybody bothered by these words yet? Tumor, cancer, cool. It's all neoplasm. Don't worry about it. So all tumors have two components. There's the neoplastic cell population, which is the cells that are actually cancerous. And then there's a stroma component. So these are not neoplastic cells. These are cells in the immediate environment of the tumor that interact with the tumor. There's growth factors, cytokines, stuff like that, that's submitted back and forth. And so there's communication between tumor and stroma. So that stromal component, it's not neoplastic, but it affects how the neoplasm behaves. So it's a really important part of the tumor. So together, all these non-neoplastic stromal components make up what we call the tumor microenvironment. That's a pretty hot area of research right now. Previous anti-neoplastic research has focused very much on what can we do for the tumor cells, but then you're ignoring a large part of the interactions and the feedback and the growth factors and stuff. So recently, a lot of groups are now studying more, forget the tumor cells, what's going on in the tumor microenvironment, and can modify that to affect how this tumor is managed. So in here, when we're classifying a tumor, we're going to do it based on the population of neoplastic cells. So this is the main guy. However, you need to understand that all these stromal components, all the fibroblasts, the blood vessels, the immune cells that are in the tumor, all this together exerts a lot of influence on the behavior of the tumor. So it is an important part, but when we're naming it and classifying it, we're basing it on the actual population of neoplastic cells. A really important common example of stroma and tumor interacting with each other is this term called desmoplasia. So what this is it's an excessive collagen produced by fibroblasts, and it's induced by tumor cells. So the tumor cells are communicating with fibroblasts saying, I want you to produce a lot of connective tissue. Fibroblasts are like, okay. They're dumb, they don't know, they just do what they're told. But it's a little bit funny, there's something about tumor-induced fibrosis that it's a little weird. So over here, this collagen is nice and pink. That's usually what fibrosis looks like. We looked at it a lot a couple weeks ago. Tumor fibrosis or desmoplasia often has like a weird blue tint to it. Can you guys appreciate that? So all these lumps of cells are tumor cells. Everything around the tumor cells is desmoplasia. It's also called a Skier's response. When you meet Dr. Russell next year, he's Scottish, ask him to pronounce this word. Not disappoint. Skittis. Everybody see that? Unusual, weird fibrosis. Okay, so you guys don't have to know this, memorize it, just this is kind of an example of what I'm saying. There's a lot going on in the tumor where it's interactions between tumor and everybody else around. There's lots of players and they're all acting together to affect how the tumor behaves and responds. All right, so tumor types and nomenclature. To be able to name a tumor, you've got to know a couple things. We're going back to tissue types and regenerative capability, and we're talking about what is the germ line of the cell origin. So remember, we talked about epithelial versus mesenchymal. Mesenchymal includes white blood cells or leukocytes. We group those separately for tumors because they behave separately. So the three major lineages of tumor are epithelial cell, mesenchymal cell, round cell. Round cell being mostly leukocytes. You will notice that leukocytes are essentially mesenchymal, but again, we classify them differently because they behave very differently from other mesenchymal tumors. Someone name a mesenchymal tissue type. Uh-oh. What? Synoviocytes. More? What? Bone marrow are leukocytes. So they are technically bone oocytes. Who are those guys? Osteoclasts. Osteocytes also. Osteoclasts also. Fibroblasts, angioblasts. Those are all mesenchymal. Okay, so three major germ lines that you need to worry about for naming neoplasms. That is the first thing you have to answer. What is the germ line of the cell of origin for this tumor type? Is it coming from an epithelial tissue? Skin, mucosal membranes, glands, solid organs, liver, thyroids, right? Kidney. Mesenchymal is going to be fibroblasts, osteoblasts, you notice the trend here, chondroblasts, adipocytes, so fat cells are mesenchymal. Round cells are mainly white blood cells, leukocytes, right? Everybody understand that before we move on to the next part? It's foundational stuff, y'all. So once we decide the germ line, round epithelial or mesenchymal, we next move on to the second phase, which is it benign or malignant? I'm going to teach you how to tell if it's benign or malignant by looking at it, or at least guess. But you need to know first how we name them. So the way we name them depends on if it's epithelial, mesenchymal, or round, because there's a different system. If you have an epithelial tumor, if it's a benign tumor, you add oma to the end. So papilloma, adenoma. Adeno means glandular. So an adenoma is a benign tumor of glandular epithelium. Thyroid adenoma, right? Adrenocortical adenoma. If an epithelial tumor is malignant, we add the term carcinoma. So carcinoma, crab, crawling, invasion. So a carcinoma is malignant by definition. When you see carcinoma in the name, that tells you it's a malignant tumor. If you see oma at the end of the name, it tells you it's benign. So squamous cell carcinoma, malignant tumor of squamous epithelium, skin. hepatocellular carcinoma, malignant tumor of hepatocytes, thyroid carcinoma. And again, adeno, if we add an adeno, it means it's a glandular epithelium specifically, so a mammary adenocarcinoma or an adenoma, salivary adenoma, adenocarcinoma. Not important. If it's mesenchymal, same rule for benign, we're just gonna add oma. So fibroma, hemangioma, lipoma, osteoma. If a mesenchymal tumor is malignant, that's not a carcinoma, it's a sarcoma. Osteosarcoma, hemangiosarcoma, fibrosarcoma, liposarcoma. You guys have heard these terms before. You probably didn't know what all they implied, right? So if you have a sarcoma, it's of mesenchymal origin. If your prefix is naming a mesenchymal tissue, you better have sarcoma at the end and not carcinoma, right? There is no such thing as an osteocarcinoma or hemangioadenoma. That doesn't make sense. You're saying opposite things. Round cell tumors are the most frustrating because there's no naming convention. We don't have this nice standard friendly thing. We just kind of call them whatever we feel like. So a mast cell tumor, is that benign or malignant? Benign? Malignant? No clue? Go either way? Go either way. What grade is it? The grade 1, 2, or 3? They have different behavior. Grade 1s are pretty benign, grade 3s are more malignant. We only have the term mast cell tumor. We can say it's high grade, low grade, but there is no mast cell sarcoma. Okay. Lymphoma. So oma should mean it's benign and lymphosarcoma should mean it's malignant, right? False, doesn't work. Lymphoma and lymphosarcoma are the same thing. Those terms are interchangeable. They're both a malignancy of lymphocytes. I know, sorry, I'm not responsible for these names. I'm just passing along the information. Histiocytoma, histiocytic sarcoma, those are two different things. Those are not interchangeable. They're separate tumors with different behavior. So these you just kind of have to memorize. Sorry, but it's a short list, so that helps a lot. Epithelial mesenchymal you can figure out, just use the system. Round cell tumors, memorize, short list. Some are interchangeable, some are not. Any questions on the foundational, super important stuff? So let it sink in. All right. So round cell tumors. These are made up of round cells. So they're primarily leukocytes, lymphocytes, macrophages, mast cells, etc. When we're talking about all these cell lines of origin or germ lines, think about how the normal cell would behave. Round cells, when they exist in groups, there's no cohesion between them, right? They don't have cell-cell junctions. They're not embedded in a matrix. They're just round cells. They're individualized, right? So when a round cell makes a tumor, those cells are going to be loosely arranged. They're going to be in loose sheets. They're going to be individual. It's going to be a mass of round cells, and there's not going to be any cohesion together. So because there's no cohesion or architecture, these cells are going to exfoliate really easy on cytology. You stick a needle into those cells and just, it's like aspirating a lymph node. They'll be like, okay, guess we're going along for the ride because they're not attached to anything, just round cells. This is also going to make the tumor very soft because there's no architecture in there. There's no structure. It's just like squishy, kind of toothpastey, usually soft pink. It's especially for lymphoma. So some histiocytic sarcomas can be a little bit more firm, but a lot of round cell tumors will exfoliate very easily. So they're easy to diagnose on cytology. The masses are often soft, especially if they're lymphocytes. So lymphomas are often very, very soft. There's a couple different presentations. So when you think about lymphocytes and their tissue of origin, where do these cells come from? The bone marrow. Most of them are coming from the bone marrow. Some of them might be in the secondary lymphoid organs, so we might be in spleen or Peyer's patches, right? So those are the places where a lymphoma is going to arise. However, because it's in those places, it automatically has contact with blood and lymph, right? So that kind of explains why a lymphoma is malignant, because it's in your blood and your lymphatics. And by definition, a tumor that has reached your blood and lymphatics is malignant because it has metastatic capability, right? That makes sense? So these tumors can do a lot of different things. They can cause a solid mass, but they can also infiltrate through the blood and cause diffuse enlargement of a whole organ. For example, this liver, this is a dog liver with lymphoma. If we still had it in the body, you would see the margins are extending well beyond the costal arch. It tells you it's enlarged. And these borders are rounded. The edges are rounded. It's very swollen. It's also pale. There is an enhanced reticular pattern if you look super close. So this is lymphoma in a liver. It is diffuse, so it's hard to appreciate. Versus this, here we're at an ileocecal junction. Here's ileum, ileocecal junction. Here's cecum and colon. So these are the ileocecal colic lymph nodes, and they're effaced by lymphoma. I would say the ileocecal colic nodes are effaced by a focal, let's see, 2, 4 centimeter soft, pale, tan, pink mass. It's fairly well demarcated, I guess. So lymphoma can look like multiple things, or round cell tumors can look like multiple things. And when they're widespread, we don't really call them metastatic because they were in the blood and lymph to begin with, right? So we call them multicentric. So we say a multicentric lymphoma rather than a metastatic lymphoma, because metastatic lymphoma doesn't make sense because it's already in the blood and lymph. Does that make sense? See some scowls, yeah.
Do you ever refer to lymphoma as metastatic?
It doesn't make sense.
Even if it were like in the blood, then it made a solid mass, and then that solid mass started.
It's already in the blood.
More.
It's already in the blood. The definition of metastasis is enters the blood or lymph and travels. That's any lymphoma.
When you say widespread, do you mean like we're seeing evidence of it in multiple organs?
Yeah, so if these are from the same animal, these two tissues, we would say he has multicentric or disseminated lymphoma. We would not say he has metastatic lymphoma.
Is there, my understanding of what you're saying is that all lymphoma is
Malignant, yes.
Okay.
Again, there's different types and grades, so there's better and worse lymphomas.
Is that true for all round cell tumors or just?
Is that true for all round cell tumors? No, there are benign round cell tumors. Yeah. So on histo, this is what it looks like. It looks like a bunch of round cells. There's no cohesion, there's no architecture, there's nobody else in this field except for neoplastic lymphocytes. If I stuck a needle in here, I would suck a bunch of them out because they're not hanging on to each other or anything else. So I'm going to get lots of cells on cyto for almost all round cell tumors. I'm not going to go too deep into these because I'm not a clinical pathologist. I hope we all graduate with an ability to recognize mast cell tumors on cyto. That's like minimum basic competency. Purple granules, mast cell tumor. Is it benign or malignant? Depends, you got to grade it. But here's the flavors. This is all of the round cell tumors that there are. Basically. Except there's some weird ones. There's weird leukemias and stuff. Okay, epithelial tumors. So these are your glandular organs, your parenchymal organs, your skin, your mucous membranes, all of your adnexa. A lot of your body is epithelial. So any of these tissues, cells, again, think about the normal architecture of these tissues. Then go back to microanatomy. The cells are always going to be arranged in clusters. Epithelium hang out together. They have cell-to-cell junctions. They're usually attached to a basement membrane. And they make structures. Sometimes they make little tubules. Sometimes they make islands. Sometimes they make little glandular structures. Sometimes they make adnexa. So there's an organization to them that we recognize as classically epithelial. Does that make sense? Not sure. Okay. The cell shape. Again, go back to microanatomy. What options are there for cell shape for an epithelium? It could be squamous, cuboidal, columnar, transitional, pseudostratified, stratified. So those are the shapes we're gonna see. Neoplastic cells might exfoliate, by that I mean stick a needle and pull out some samples for cytology, you might get some cells, but there's adhesion to a basement membrane to each other, so they're not gonna exfoliate as easily as a round cell tumor would, that's not holding on to anything, including its friends. When they do exfoliate, you often get clumps of cells together, so they maintain their junctions and you will see cells in clumps on cytology. That's a clue that it might be an epithelial origin tumor. So cytology might be useful, but for diagnosis, it depends how much desmoplasia or how much collagen is in this. You can imagine if you stuck a needle into this tumor, we're probably not going to get very much because most of this is collagen. It's scar tissue. How well is scar tissue going to exfoliate? Okay. And most of the population is scar tissue, not neoplastic cells. So the ability of cytology to diagnose an epithelial neoplasm depends on the neoplasm. Question retracted. Okay. Okay. Most epithelial tumors are firm. So most round cell tumors are soft to very soft. Most epithelial tumors are firm. Remember, soft is your lip, firm is your nose, hard is your forehead. Some of them are cystic. If they're making something and secreting into a space, it will be cystic. So here's a couple examples. Here's a thyroid gland. I would say the thyroid gland is multifocally, you have two masses, expanded by firm, tan to pink, well demarcated, well circumscribed masses that are compressing but not invading adjacent tissue. So that's a thyroid adenoma. Is this benign or malignant? It's benign. Oma. Adenoglandular, oma benign. This is a liver. I would say these might be continuous. I can't tell if this is one lesion or multiple. Let's assume it's one. So I would say focally expanding the whatever lobe of the liver this is a raised pale pink to white, firm. I would describe this maybe as multicystic. I think a lot of these little bumps are teeny tiny little cysts, and if we got close enough, we would see fluid in them. The mass surrounds but does not invade the gallbladder. The mass is not encapsulated but well demarcated. So this is biliary cyst adenoma, benign or malignant. Benign, because it's an oma adenoma. It's a cyst adenoma, so that's a specific type of adenoma, but it's benign and it's coming from biliary epithelium. Oral papillomas. So the tongue of this dog, I would say about 70% of the surface area, the tongue of this dog is covered by white, papillary or frond-like or exophytic masses arising from the epithelial surface. So these are papillomas. They're benign or malignant? Benign, oma, papillomas. If you have a condition of multiple papillomas, you have papillomatosis. Remember, osis is a specific condition of, so papillomatosis is a condition of many papillomas. Anybody know what causes this? A virus. Which virus? Papillomavirus. You guys are so smart. Okay, so epithelial tumors on histo can be variable. Epithelial tumors that are malignant are the ones that are most likely to induce that desmoplastic response or the scirrhous response or the weird fibrosis that goes with the tumor. So a malignant epithelial tumor is less likely to exfoliate well because of all this scar tissue in there. Yes.
So this is my question, is the tumor recruiting fibroblasts, normal fibroblasts in order to build this collagen matrix around
Yes.
it?
It is recruiting normal cells to its cause.
So then the fibroblasts aren't neoplastic
Nope.
cells either, it's just
Nope.
neoplastic cells. So-
Yep. Yep. Isn't that creepy? Cancer is really creepy for not being like intelligent at all. Okay, so imagine we stuck a needle into this and tried to suck some cells out. Maybe it'll work. I hope you stuck it right here and not here, right? So highly variable for epithelial tumors. Cytology might be useful for diagnosis, it might not. When you have an epithelial tumor that exfoliates on cytology, you're gonna see cells in clumps because that's how they live in the body. Epithelial cells need friends. They never go to the bathroom or anywhere by themselves. Epithelium always travels in groups. So on cyto, if you see them, you're gonna see them in clumps. You're gonna see nice cell-cell junctions, clear cell borders. Mesenchymal tumors. So these are the connective tissues, bone, cartilage, blood, vessels, things like that, fibroblasts. In general, these tissues are extremely tough. Think about scar tissue, think about bone tissue, think about cartilage. Cells are going to be arranged in, we call it bundles, streams, and whorls. They're essentially interlacing and producing a bunch of matrix between them often. So they are very, very tightly adhered to each other, more so than epithelium. Because these are making the normal function of these cells when they're not neoplastic is often structural, right? So the tissues that mesenchymal cell types produce are often very firm to hard. Round cells, very soft, no cohesion. Epithelium, cohesion, some structure, firm. Mesenchymal tumors, very firm to hard. If we're talking about a tumor of bone or cartilage, it will be hard. The cells are spindle shaped, so think of a fibroblast. It's very small amount of cytoplasm. It's like a spindle, and they're interlacing together to form a structural network. Because of their arrangement and their adhesion and their structural function, these cells do not exfoliate well at all. So cytology is unlikely to help you diagnose a mesenchymal tumor. Round cell tumor, very good at cytology. Mesenchymal tumor, terrible on cytology. Epithelial could go either way. Okay. A lot of these tumors, because if you think of the normal cell type, they're cells that produce a lot of stroma, osteoblasts, fibroblasts, angioblasts, chondrocytes. There's often a very prominent stromal component. So osteosarcomas produce a lot of osteoid, which turns into bone. So that's technically non-neoplastic. It's bone, it's extracellular mineralized matrix, right? It's inert, but it's going to be part of that stromal component of the neoplasm. The exception to a lot of these rules is tumors of endothelium, so blood vessels and lymphatic vessels. Again, think about the function. They're making vessels. So many of these tumors are going to be very soft because they're going to be fluid filled spaces, because these cells make the lining of vessels that then fill with fluid. So they're going to be soft, cystic, they may exfoliate, but endothelial cells are technically mesenchymal. They just act a little bit different because their function is a little bit different. Okay. So here's a dog humerus. I would say the proximal head of the humerus is, what's the word for this? Is it expanded, effaced, replaced? It's hard. I think it's I think I'm gonna go expanded because I can still outline where the bone was, but there's areas where I lose it, right? So I'm gonna say it's poorly demarcated, right? I can see where normal bone is and tumor is here, but here, I can't really tell what's normal and what's cancer, right? So I'm gonna say it's poorly demarcated, it's invasive, it's expansile. I can't tell if it's coming outside in or inside out. Does that make sense? Did this start in the marrow cavity to explode out through the cortex, or did it start on the periosteal cortical surface and eat into the bone? I have no idea, but this is highly invasive and malignant looking and scary, right? So this is an osteosarcoma. Sarcoma, a malignant mesenchymal tumor. It has to be mesenchymal because it's osteo, it's a tumor of bone. This is a diaphragm, so we've removed the diaphragm and just laid it flat like a sheet. I guess this way, like a sheet. For my description, I would say, let's see, about 40% of the diaphragm is covered by multifocal to coalescing, soft red fluid-filled nodules of varying size. On aspiration or puncture of these nodules, they contain what appears to be blood. So this is metastatic hemangiosarcoma. Is this benign or malignant? Malignant, how do you know? Sarcoma and it's metastasized. If it has metastasized, that is the definition of malignancy. Okay, so even if I showed you this, can you tell from this pattern that this is metastatic?
Yeah.
See the shotgun blast? Yeah. The other question is, could this have arisen in the diaphragm? How vascular is the diaphragm? Not super. So I'm real suspicious that a hemangiosarcoma started in the diaphragm. That doesn't make a lot of sense to me. Here's a uterus. I think this is what's left of the uterine lumen. So here we're looking at the wall. The wall of the uterus is focally massively expanded by a well demarcated, extremely firm, white fibrous mass. This is a leiomyoma. Do you know what that is? It's a benign or malignant. What? It's benign because it's an oma. Can we break down that word anymore? Myo is muscle. So it's a kind of muscle. We're in the uterus. Who lives in the uterus? Smooth muscle. This is a benign tumor of smooth muscle. This is also called a fibroid in human women. It's very, very common in old ladies of any species. By old, I mean my age, I have one, at least.
The leiomyoma.
The leiomyoma.
Smooth muscle.
Yes, smooth muscle. Versus a rhabdomyo is striated muscle. Okay, so again, here's what they look like on histo. It looks like connective tissue. It's not coming apart. You stick a needle in there, they're gonna be like, no way. I live here, I have a job to do. I'm making structure for this tumor. So this is a fibrosarcoma, benign or malignant? Malignant. Malignant tumor of who?
The
Fibroblasts. You won't pass this week, as far as I'm concerned. Here's what a mesenchymal tumor looks like on cytology.
That's like it.
Nothing there. There are some mixed tumors. It's uncommon. They can be benign or malignant, and either component can be benign or malignant, so a little bit more confusing. But mixed tumors are tumors that are composed of more than one neoplastic cell population. So this isn't a stromal thing. This is literally two different cell types that are neoplastic in the same tumor. Either cell type can be benign or malignant, or both can be benign or malignant. So here's some examples. These are all extremely common. I see these all the time on biopsy. Probably my favorite is a hepatoid adenoma. Anybody seen one of those before yet in practice? Perianal gland tumor. They are super common. They are very common in old dogs, and they are hormonally responsive. So if you castrate the animal, their butt tumors will shrink and go away. So stop kidding. Isn't that nice? But these are composed of two different cell types. There's these, we call them hepatoid cells because they look like hepatocytes, even though they're glandular epithelium. So all these big pink guys that look like hepatocytes are the hepatoid cells. And then all around the edge of these lobules are these smaller guys. These are basaloid reserve cells. They're kind of like a, I don't really know what they are. They're kind of like a, maybe a stem cell, a support cell. I'm not sure that anybody knows or cares. But that when these become neoplastic, both of those components proliferate together. So this is technically a mixed tumor of two different cell types. Teratomas are also a mixed tumor. Everybody heard of teratomas before? Terato literally means monster. So this is a monster tumor. What? This is a tumor that forms from a single totipotent or pluripotent stem cell. So what cell in the body are we talking about? Either a or a. Where do you have totipotent stem cells?
Bone marrow.
You have pluripotent stem cells in your bone marrow. Where do you have totipotent? An embryo,
Last.
gonads, sperms and eggs. So these are usually tumors in the gonads. They're testicular or ovarian majority of the time. They're able to form multiple germ lines. So when within one tumor, you can have epithelial, mesenchymal, neural, round, multiple germs. So that tells you there's something going on, because usually a tumor arises from a single cell of a single germline, right? And develops into that germline. Here, the single cell is able to diverge into many germlines. So you get any of these, any or multiple or all of these. Here's a human one. It's got a tooth and some hair and some skin, and it's got some glandular, it's like secreting something. It's just very cute, delightful. Can be lots of things in here. Appearance is highly variable depending on what's in them. Sometimes they just look like little balls of shmoo. They look like nothing. Sometimes they look like freaky tooth monsters. So here's a ovarian teratoma from a dog. Over here we have haired skin with hair and adnexal structures, skin surface. Here's a piece of cartilage. Here's some bone surrounding a tooth. Here's like a little nerve or some neural tissue. Up here, there's some collagen. I don't know what that is, but I'd like to examine it more closely. But this has multiple germ lines in it: epithelial, mesenchymal, at least 2 out of 3, and neuroectoderm, nerve tissue. Okay, and then a couple lesions that are, well, tumor just means a swelling, right? But these are not neoplasms. These are neoplasia-like lesions or tumor-like lesions. So these are generally benign developmental, but not always congenital lesions that can look like tumors to owners. So you will get owners coming in and saying, hey, my dog has a mass on the foot, between the toes, on the elbow, over pressure point, whatever. And they will remove this mass, potentially remove the toe with it. One of my most common diagnoses is this. It's called a fibroadnexal hamartoma. So a hamartoma is disorganized but mature, meaning it's not neoplastic. It's just disorganized and it's in a normal location. So this is disorganized fibrous tissue, collagen, and adnexal tissue, both of which are normal in the skin, but the arrangement is abnormal, so it's making a weird nodule. And what happens is you have hair follicles that are deep in the dermis. They fill up with keratin, they rupture. That's highly inflammatory, and you get a pyogranulomatous response because keratin is foreign material. You then have chronic inflammation, swelling. They can ulcerate. The dog will chew at them. So it looks like a tumor. They can get very big and swollen, but it's just this fibroadnexal hamartoma. These are so common. Nobody ever taught me about this in vet school, so you're welcome.
You use the word adnexal a lot.
Adnexa are, not learn adnexa in microanatomy. No, so in your skin, you have your epithelium, right? So you have epidermis, and then you have dermis, collagen, connective tissue. Also in your dermis, you have hair follicles, right, that emerge, and you have little hairs. Around your hairs, you have little sebaceous glands, you have little sweat glands. All of this is adnexa.
The whole hair structure.
The hair and all, the follicle and all its friends, sebaceous glands and apocrine glands, sweat glands. All the stuff that's not skin, but is part of your skin. So all these things, so here, here, these are adnexa, all these hair follicles in my teratoma, skin surface is here, these are all hairs, adnexa, all that dilated, weird adnexa. There's also a thing called a choristoma. These are way uncommon, you'll probably never seen them. I don't know that I've ever seen one that was really impressive, but this is kind of the flip of the hamartoma. This is normal, mature, non-neoplastic tissue, but it's in the wrong place. Ectopic means you are in the wrong place. You're not where you're supposed to be. These are really uncommon. Again, these are usually developmental. So here's a pulmonary choristoma. This calf has probably multiple other birth defects and has a weird lung thing growing in its abdomen. If we cut into this microscopically, it would look like normal lung tissue, but it's not supposed to be in the abdomen of this baby thing, right? Super, super uncommon. You won't see this, don't worry about it, but you gotta know the wording.
And those usually compatible.
Yes. Questions? Really?